has a key role in popularizing OCT in Kerala, one of the first to use OCT in Kerala. And it's a pleasure to have Biju with us today. Over to you, Dr. Biju.
Good morning, everyone. Thank you, Dr. Thomas and Fortuna Family Club for this opportunity. Before we jump into the topic, let us fly back to the period of 1890s when three brilliant minds were working hard and racing against time to propose what we now know as the special theory of relativity. Two of them, Lorentz and Poincaré, they were far ahead of the time, but they held on to a belief that there was an omnipresent light-carrying medium throughout the universe called the luminiferous ether. Nobody knew whether this existed, nobody could prove it or disprove it. So, equipped with his new invention, the Michelson's interferometer, Albert Michelson joined hands with Edward Morley and set up an experiment to prove the existence of ether. It's not to disprove, but to prove, because they also believed it was there. And that experiment, the Michelson-Morley experiment, returned a null result, which means that they could not prove the existence of ether. And Michelson himself told that this was a major failure in the experiment. However, the null result confirmed the beliefs of one of the most brilliant theoretical physicists. And with the ether out of its way and equation, Albert Einstein went ahead and proposed the special theory of relativity. And he gave us the most famous equation, E is equal to mc squared. So the crux of the point is that Michelson's interferometer has played a major role in changing the face of our lives in the modern era. And that experiment, Michelson's Morley experiment, used the Michelson's interferometer, a simple device, a beam splitter which splits a beam of light into two parts. One which goes straight ahead, one is perpendicular, and they are reflected back onto the beam splitter where they create interference when they join. And these fringes carry data, important data about the path of the light and the quality of the fringes. Though the experiment was considered a big failure by Michelson himself, his invention has changed modern optics, and we use it in astronomy and also in medical imaging. The LIGO, the laser interferometer, gravitational wave detector, one of the third facilities coming up in India, in Pune, that uses the interferometer. And we as ophthalmologists every day use it. And every OCT image that we see has took life from that most brilliant failure in science. And in OCT, we replace this mirror with the retina, and the interference fringes carry all the important information about the depth profile and reflectivity of the various layers of the retina through multiple A scans, and then we get an optical biopsy. I'm sorry, this is the only picture I have of that first OCT that had been commercially available. It was a huge machine, it filled the whole room, and it worked on the time domain principle, where a reference mirror is moved. Because it has to move, it was slower, but it gave us a reasonably good optical biopsy of the retina. And then we moved on and to Fourier transformation, which is a mathematical series which makes things faster. And both the OCTs that we now use, both the spectral domain and the swept source OCT, use this technology. And one uses a spectrometer, other uses a swept source of 1050 nanometers, which gives a better penetration into the choroid. We are looking at the reflectivity characteristics of the retinal layers in OCT. And from this you can see that the cellular layers, which are the outer nuclear, inner nuclear, and the ganglion cell layers, are hyporeflective, whereas the regularly arranged retinal nerve fiber layer as well as the plexiform layers are hyperreflective. And most of these layers will have some reflectivity at the boundaries because of the faint changes in the refractive indices. Before we start, I would like to warn that never rely on a single scan. Now this looks like a macular edema, but if you move the scan down, then you can see it's not a macular edema, it's actually a macular hole. So when you take a look at the scans, make sure you see the entire scan profile before you make a decision. And also look at the scan on a grayscale, because our eyes are more suited to detect small brightness changes on a grayscale than the hues on color. So you can see that the colors, when they are removed, the layers stand out so properly. And when you start naming those layers, make sure you are kept abreast with the current terminology that is used. This is the current terminology that is now we are using. And I would recommend this article by Dr. Bunabende, which tells about all these layers. But to summarize, we can say that the retinal nerve fiber layers and the other synaptic layers are hyperreflective, whereas the cellular layers, the ganglion cell layer, inner nuclear and outer nuclear, are hyporeflective. Now that we know the basics of OCT, let us see how we can interpret OCT. We should start in a systematic way, right from the top to the bottom. And the vitreous cavity, you may find a posterior vitreous detachment which may be complete or partial. You could see vitreous cells in a case of uveitis. This is a case of retinochoroiditis. You can see the inflammation and the response here. And sometimes you see these hyperreflective dots which are asteroid hyalosis, and they cause backscattering or shadowing. Then you come on to the next part, is the vitreoretinal interface. Is it normal or is it abnormal? Here it is a vitreomacular traction, the retina is pulled up. Is there any epiretinal membrane? Yes, there is an epiretinal membrane as a layer on top of the retina, and also a PVD is also seen. The foveal contour is usually a shallow V, as you can see here. If there is a widening of the V, then you should suspect a foveal atrophy. If there is a break, of course, you all know it's a macular hole. And the foveal contour can be obliterated. It can be obliterated by two ways. One is a pulling mechanism, which is this vitreomacular traction, or a pushing mechanism, a macular edema that can cause, in this case, a mixed type of a situation where you have both a pulling mechanism as well as diabetic macular edema causing a pushing mechanism on the foveal contour, distorting it. And the inner layers, often we see these cystoid spaces which are hyporeflective spaces. You can also come across hyperreflectivity or abnormal reflectivity like this in a case of cloudy swelling in central retinal artery occlusion. Hard exudates are bright objects here. And also if you have this kind of hyperreflectivity in the middle layer, it could be something called the middle maculopathy, which is again an ischemic event. Sticking on to diabetic maculopathy, you can have a spongiform edema. This is a hard exudate plaque, and cystoid macular changes with an early subfoveal serous detachment or a submacular detachment (SMD), and a larger kind of a subfoveal submacular fluid there, subretinal fluid. Sorry. We can also look at the therapeutic efficacy of the treatment that you do. And this is a patient one night with a relatively bad retina. We started with Avastin, but she could not afford, so we put her on fenofibrate, and surprisingly the fluid got completely absorbed and she had a marginal improvement in vision and stabilized. OCT also can help you judge whether there is a central involvement, which is one of the ways we decide how we manage these cases. If the central subfield 1 millimeter is involved, it is a central involved maculopathy, whereas if it is not, it is a non-central involved maculopathy. Looking at the outer retina is a very important aspect because it has the external limiting membrane, the ellipsoid zone, and the interdigitating zone. The three of them constitute the health status of the photoreceptors and can affect, any of them can get affected in a patient who has a poor visual acuity. This, along with the RPE Brooks membrane complex, form the outer four bands in the OCT that we see. Beyond that, we have the choroid, and to image the choroid you need either an enhanced depth imaging or a swept source OCT. And mostly we look at the choroidal thickness, which is more in pachychoroid syndromes, or thinned out in age-related macular degeneration or conditions like high myopia. We look at the biomarkers, which are fluid or structural. And fluid, whether it is intraretinal or subretinal, because intraretinal fluid is more harmful, and subretinal fluid up to about 200 microns is said to be can be tolerated, it seems. The retinal biomarkers, the most important one that we see in vascular diseases like diabetic maculopathy as well as vein occlusion would be disorganized retinal inner layers, and then in other conditions like CSR, PCV, you see double layer side. And of course, we did discuss about integrity of the photoreceptors, and these are the other biomarkers. The choroid biomarkers, mostly the choroid thickness is what we commonly use, And some of the biomarkers we can have a look at. This is the inner retinal layers clearly seen here on this side, but here it is absent. So this is a drill, and this is a subretinal hyperreflective material. This could be a choroidal cleft, and this is the double layered sign. We can also follow up cases after surgery to look for in macular hole the closure, whether the closure is adequate. This is a type 1 closure with a good recovery of the outer bands of the retina. Now some interesting cases, this is a torpedo maculopathy. Double torpedo is one of the rarest cases. A double torpedo here which has a characteristic type 1 kind of an OCT reflection here, OCT picture here, and a type 2. The second torpedo has a type 2 kind of source. So both the types of OCT picture are seen in this patient. And thanks to Dr. Mahesh, we were able to do a multimodal imaging for this case, which is a giant RPE tear with a retinal detachment and choroidal detachment. After surgery, we found that this is a rolled edge of the RPE detachment and RPE tear, and it has been accepted in IJO. Coming to the recent advances, we have AI, which can automatically segment and give you all the pathologies in case you miss them. You can have the OCT on a microscope, which can give you on-the-fly decision making, and we have functional OCTs like polarization sensitive OCT, which can help in making exact GA assessment, and adaptive optics makes cellular layer visualization much more better. This all started with the Michelson's interferometer. And when you see, you think it's not just a Michelson's interferometer, it's much more. There are so much of optics going on below the Michelson's interferometer. That is a beam splitter there, and this is the table which holds the Michelson's interferometer. There is a lot of things happening. It is a space age technology that is sitting in your OPD. And it all started with this interferometer by Michelson, which is now resting on a pool of mercury. And from this, we got OCT, which makes us manage these patients well. Thank you very much.